When I found out about my HIV status, I felt very bad because I never thought I can be in that situation. Yes, I felt very bad and I was thinking about dying at that moment.
Agora que eu estou descobrindo a vida, só serviu para mim me tornar uma pessoa melhor, porque até então eu era uma pessoa assim egoísta, e muito fútil. Não dava valor assim às verdadeiras coisas que você tem que dar valor na vida.
I remember they took my blood and they left me sitting in the clinic room while they went and got the doctor, and suddenly then it hit me like a sledgehammer, and I suddenly had this wave of despair come over me.
In 2005, Rob tested positive for HIV, the virus that causes AIDS. Years earlier, it would have been a death sentence. But as a nurse, Rob knew treatment was now available. Still, he went through a crisis remembering many friends who died of AIDS.
I knew that wasn't going to happen to me because I knew we had moved on from being a fatal disease to a chronic disease. I knew there were excellent meds on the market. I think what I did go through was the survivor guilt, because I suddenly thought of all the very good people that had died of this disease, and here was I with the same thing that had killed them, but it wasn't going to kill me.
HIV kills by destroying the body's defenses, allowing other infections to go unchecked. The final stage is called AIDS. But in the mid-1990s, researchers found that a combination of medicines called antiretrovirals, or ARVs, could suppress the virus. While not a cure, they prevent AIDS from developing. One of the most important questions facing doctors ever since is to know when people should start the medicines to keep them healthy as long as possible.
There was pretty much immediately a polarization of views. There were sort of visionary academics like David Ho in the US who was saying hit hard, hit early, and pushing for a very radical approach to treating HIV with all three drugs at the first opportunity. But around that time, this was in the, looking at really 97, 98, were the very first reports of the problems of combination therapy. That led to a reappraisal of the risk of the drugs against the likely benefit.
ARVs were found to have serious side effects. Treatment was expensive. It was for life, and people had to remember to take pills several times a day, or else the virus could mutate and the medicines will no longer work. So it was decided only to start treatment when people really need it, when their own defense system is failing. This is measured with a blood test which counts CD4 cells, the defense cells that HIV destroys. Treatment often starts years after first infection. When first diagnosed, Rob still had a healthy CD4 count. Indeed, because he had regular tests, he knew he had only just caught the virus. At this first stage, known as acute infection, HIV invades the body, multiplying to very high levels, making people very infectious to others.
I had a viral load that was sky high. In fact, I remember the registrar at the time getting quite excited because it was such a high figure. And because of that, they were very keen to ask me if I would take part in a trial because they don't get that many opportunities to get people so early in the disease process.
Doctors can only find out how best to use ARVs by trying different strategies on real people. there have been thousands of clinical trials, each adding its grain of knowledge. Rob knew he owed his survival to all the volunteers in previous studies, so he didn't mind being asked.
Friends got quite upset on my behalf, you know, why are they asking you to do this? But to me it seemed quite natural. This was a way for me to give something back and trying to help. I wanted to sort of try to make it a positive experience, if you like. I wanted to try to do something.
The clinical trial Rob joined, called Spartac, was looking at one aspect of when to start ARVs. It was designed to find out if giving a short course of treatment to people like him, who had only just caught the virus, might help them get over the initial acute infection. Might their immune system stay healthy for longer?
So the question was, if you had a short amount of drug to help your body, if you like, cope with this virus when it had only just become infected, which was a time when we knew that the virus was really quite debilitating to the immune system because your body is yet to get used to having it, then you could stop it and you'd have a longer period of time when you didn't need treatment before you had to go back on treatment again.
Researchers needed more than 350 volunteers for Spartac, so they formed partnerships with research centres to recruit in 8 different countries. Spartac is the largest randomised trial where volunteers have been asked to take ARVs straight after infection with HIV. Fears they would not want to proved unfounded.
Most individuals that I saw wanted to take medicines because they wanted to feel that they were in control of this virus. Okay? Some individuals had a lot of symptoms with regards to their HIV infection, and they would think that potentially taking this medicine would resolve a lot of those symptoms. So I think a lot of individuals were much more keen to go ahead to take medicines at this time.
Volunteers were randomly assigned to 3 different groups. One group did not take ARVs early, following current practice. A second group took a short 12-week course before stopping to wait until treatment is really needed. Rob was glad he ended up in the third group, who were given a 48-week course of treatment before stopping and following current treatment guidelines. He responded well, and the virus quickly dropped to undetectable levels. But he had to take pills twice a day, which he sometimes found difficult. In the evening, he had to set an alarm to remind him.
I'd be sitting here, the alarm would go off at 10 o'clock. And I'd suddenly think, here we go again. And it was almost to get up and go to the kitchen. The trouble is, it does emphasise that I am a sick person if I'm starting on treatment. And I think that is one of the biggest fundamental questions about whether somebody should start treatment early or not. I think if there's very clear clinical evidence that the outcomes are improved by starting treatment, then I think we should be working to help people with that psychological barrier. But I think while the outcomes are still questionable, I think that's a difficult one.
Samalira moyo, samalira moyo, moyo, samalira moyo, samalira moyo. Ansanga tandizeni.
In Durban, South Africa, conditions are dramatically different from the UK. This is where new approaches are desperately needed to confront an epidemic out of control. Here, almost 1 in 5 people are HIV positive, and testing positive brings fear.
I used to cry a lot.
Nelly joined Spartac after finding out she had caught the virus from her boyfriend, who was already falling sick with AIDS.
And my boyfriend, he passed away. Yes. 2 months after I found that I was HIV positive, he passed away. Everything was bad. I was thinking of dying. Yeah.
Nelly's boyfriend died because he started ARVs too late. On her first visit to the clinic, Nelly would have liked to have been given medicines straight away. But she was randomly assigned to the group which did not start treatment early. On the other hand, she says she benefited greatly from the extra support given to volunteers on a clinical trial.
They were like my second family. Yes, they used to talk about everything. If I have problems, I would go to them and they will comfort me. They will give me all the support that I needed. Yeah.
South Africa's government is struggling to provide ARVs to all who need them, helping to explain why the idea of early treatment was popular among Spartac volunteers.
It brought a hope for them because I believe that it's normal for one to feel like because now I'm HIV positive, I'm going to die. But when they heard that they were going to be given a treatment, ARVs, so that brought a hope for them that they might live longer.
There was much more worry about stopping the medicines after the initial 12 or 48-week course.
Some of them, they were afraid because TVs and magazines are educating people that if you are taking ARVs, you cannot stop taking ARVs because of the side effects, also because of the resistance. So they were afraid that maybe they might develop resistance.
All the trial participants had regular blood tests and checkups. For more than 7 years, all the information was carefully collected, allowing scientists to compare the 3 groups of the trial. So it took a long time for Rob to find out if his initial course of treatment had helped or harmed him.
The similar complexities, and probably that's a result of the fact that
The results showed no evidence of harm. None of the participants developed resistance or a higher risk of illness from taking ARVs early and then stopping. The answer to the main question of the trial showed that the 48-week course did delay the time when the immune system starts to fail and people need to go on lifetime treatment. However, this delay was not long enough to make any definite recommendations for new treatment guidelines.
what our trial I think does is add to that jigsaw that people who have very recent infection who go on to treatment, first of all it's certainly safe, and second of all it may confer some, albeit small, benefit to that individual.
The benefit could be best seen in the blood test results. Rob's group had lower levels of the virus, which continued even after they stopped treatment after 48 weeks. They also had higher CD4 counts, suggesting their immune system stayed healthier. Another trend showed the sooner treatment started after infection, the better. These are tantalizing suggestions that giving a person ARVs as soon as possible after infection could benefit their immune system. But there is another important implication of lower levels of the virus for the wider fight against an epidemic, which worldwide continues to grow. Crucially, people who have less of the virus in their blood are also less infectious, and so less likely to pass on the virus to sexual partners. This benefit of ARVs is now well established. Normally, more than 1 in 3 babies born to HIV-positive mothers become infected. Clinical trials in Africa have shown that if the mother is on ARVs, then the risk of transmitting HIV to their baby drops dramatically to less than 2%. Another recent study looked at infection rates between adult couples. one of whom is positive, the other not. It showed that when the HIV-infected person started treatment early, they were 96% less likely to infect their non-positive partner. The prospect of early treatment slowing the epidemic is now causing a great deal of excitement. To do so, it will need to target those like the Spartac volunteers, who've just got the virus and are the ones most likely to infect others.
We know that people who have very recent infection, mostly themselves often don't know they have become recently infected. And so at a population level, it has been thought by modelers that maybe people with recent infection could contribute to up to 30 to 35% of all transmissions within a population.
So early treatment will need to be accompanied by much more proactive testing to identify people quickly after infection and give them ARVs before they infect others. This strategy has been nicknamed test and treat. The trouble is, doctors still don't know if it will benefit or harm individuals. It's a fine balance. Early, lifelong treatment may be harmful due to side effects or the increased risk of resistance. But starting too late might permanently damage the immune system, increasing the risk of illness, including cancer and heart disease. This, along with better drugs, is shifting the balance of opinion of when to start treatment.
What's changed is that the drugs have got easier, one pill once a day, can't get easier than that, and the toxicities have got less and are more manageable and more anticipated, so you can warn patients about them. So the starting point has crept up. Without new evidence, it's just all over the world. The starting point has crept up, and now we're at that point in history where we can say hit early, hit hard. Perhaps we need to revisit it.
The crucial missing piece of the jigsaw, whether early treatment will benefit individuals, is the subject of another study called the START clinical trial. It will recruit some 4,000 participants across 6 continents, including Africa, making it one of the largest HIV treatment trials ever carried out. It will look at whether early treatment makes people more or less prone to illness.
From a public health point of view, there's a good rationale for test and treat. It is just not practical to implement it unless we show that early treatment is also of benefit to the individual. And that is what the question START is addressing.
The START trial will not produce results until 2015. By then, in Africa, millions more will have become infected. Indeed, despite treatment, some 2 million people worldwide continue to die of AIDS each year. Some argue that groups most at risk of passing the virus on should already be getting early treatment.
Migrant workers, for example, men and women in discordant couple relationship where one partner is HIV positive, certain sex worker population. I think we can identify people at high risk of transmitting the virus and early in HIV infection. And I think starting early treatment in high-risk population would be of great advantage.
Another problem is that universal early treatment is beyond the means of most African countries. They are struggling to provide medicines even to those already developing AIDS. South Africa has 5.5 million people infected with HIV.
Currently, we don't have all the people that need treatment getting treatment. So I believe that the test and treat concept may be feasible in some countries, but not in a very generalized epidemic as South Africa. because the people who need treatment currently are not getting treatment.
On the other hand, it might be that a big investment in the short term will pay off in the long term.
It would need a lot more resources now to save resources for the future. But otherwise, antiretrovirals represent a sort of debt burden which can only increase, because without halting transmission, the prevalence of HIV infection can only rise.
To argue for such an investment, doctors need to show that test and treat will actually curb the epidemic. Another big trial called Spartac will find this out. It will provide frequent testing and immediate treatment in target areas in Zambia and South Africa. The results, due in 2016, will show how effective the strategy is at preventing transmission at a population level. To work, the strategy will need much more than just medicines. It will also need a change of attitude to overcome the stigma and fear surrounding HIV infection. In the Durban suburbs where Nelly lives, she says she tries to persuade people to get tested, but often without success.
They're scared to go and get tested. They say, no, I don't want to go and get tested because maybe I'll find that I'm HIV positive, and after that I'll be depressed. It's fine not knowing.
This is what happened to Nelly's boyfriend. She found herself unable to even talk with him about HIV.
What made me feel bad was that he passed away before we talked more about the HIV, about finding that I'm HIV positive, because he's the one who infected me. I loved him, but at the same time I hated him. Yeah, and my mind, I didn't know what was going on in my mind.
Dealing with the psychological aspects of this disease is far harder than the physical side. I was a fairly together person. I had lots of support. It was easy in that sense for me to say, I'm HIV positive, I've got to get on for it. For some people, it is a piece of news they never really recover from or cannot get their head around.
Likewise, people who have had no signs of illness sometimes find it harder to stick to treatment. In Rio de Janeiro, Brazil, Ruth Lane joined the Spartac trial at the same time as Rob. She wanted to be on treatment, but had trouble remembering the pills.
Tomar medicamento aqui para mim é o porque eu me sinto assim tão para cima, tão numa boa, que eu esqueço do medicamento. E tem que tomar religiosamente no mesmo horário todo dia. Porque eu sou louca, toda maluquete, e esses caras vão me chamar para fazer pesquisa, vai dar tudo errado.
If the difficulties could be overcome, the potential of test and treat can be seen in Brazil. This was the only developing country to start free universal treatment back in 1996, when ARVs first came out. It was controversial, spending thousands of dollars a year per patient when children still died of diarrhea. But the rationale was that unless treatment was on offer, people wouldn't get tested, so prevention wouldn't work.
Brazil never separated prevention from treatment. At that time, everyone, including the World Bank, said they should not invest on treatment. And Brazil always thought that prevention and treatment were indissociable. And now everyone says the same.
The policy has worked. Today, only 0.5% of Brazilians are infected. Yet, even here, the epidemic is slowly spreading. Ruth Lane was infected by her husband, who was also afraid to get tested, and found out he was positive very late. He subsequently died. But she remains very positive.
Não é que você pense assim, tô com HIV, vou morrer amanhã. Não é isso. Eu comecei a ver o lado positivo da vida, entendeu? A poder curtir as coisas melhor, a você poder apreciar a beleza de uma árvore, um sorriso de uma criança, você dar valor à amizade, você valorizar a vida, o sentido da vida mesmo, que você está aqui para viver, para você amadurecer e aprender, entendeu?
ARVs have given life to millions of people like Ruthlein. Now the medicines offer a wider hope. Researchers have already shown that starting treatment early reduces the risk of passing HIV on. If they can also show it benefits the individual, early treatment may offer the best hope yet of curbing the epidemic.